Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.AAAAI.org. Today's edition of our Conversations from the World of Allergy podcast series is targeted towards Academy members and really anybody interested in learning more about adverse reactions to vaccines. It's a relatively niche area, and I'm excited to take a deep dive into it with our guest. Today's guest is Dr. Karla Adams. Dr. Adams is an allergist immunologist and also a colonel in the United States Air Force. Dr. Adams is a faculty member at the Uniformed Services University F. Edward Herbert School of Medicine and program director for the Allergy Immunology Fellowship Program at Wilford Hall Medical Center in San Antonio, Texas. Dr. Adams has a clinical and research focus on vaccine and venom allergy. She was also one of the lead faculty for the new American Academy of Allergy, Asthma, and Immunology education course focused on adverse reactions to vaccines. Dr. Adams, thank you so much for taking time to join us, and welcome to the podcast.
Hi, thank you so much for the invitation to come on the podcast, Dave. It's a pleasure to get a chance to talk to you today.
Yeah, I think this is going to be really informative. I don't think we've had any of your colleagues from the armed forces as a guest in the past. Can you take a moment and just tell us more about your background and how you ended up as an allergist in the Air Force?
Yeah, definitely. It's an honor to be the first, and I'm definitely happy to share my journey as it's not a common one. But first, being a government employee, I do want to just provide a verbal disclosure that obviously these views are my own and don't reflect the official views of the Department of Defense. And on that note, so my story actually starts in Washington, D.C., Maryland area. I was fortunate enough to work at the NIH as a summer intern in college, and my mentor at the time knew I was interested in medical school, perhaps near home. So he was actually the first one to mention the Uniformed Services University, which is, we call it America's Medical Military School, and it's literally located right across the campus from NIH. So very close to home. It was definitely something that I was interested in. And as I started to look at the curriculum, I was really impressed with, just kind of the broad range of, classes that were offered, as well as like these opportunities that, at the time were not really being offered by any other school. So not to date myself, but this also happened right around 9/11. So, there was definitely kind of that sense of wanting to serve, not just from the medical side, but also, when I got the opportunity to also add military service into that, I just felt like it was an opportunity that I couldn't pass up. So applied, finished medical school, and then did a pediatrics residency in San Antonio. I had rotated through the allergy department as a fourth-year medical student. Just loved just the allergy and immunology concepts that I had learned. So decided to apply for fellowship after being staff for a few years. And then, 20 some odd years later, I'm still in and continue to serve. I've had a great career with some really kind of unique experiences, which includes my current job as program director for the Wilford Hall Fellowship. So I would say that it's literally the best job in the military. So that kind of gives you an overview of, my previous training and how I ended up to where I am today.
Oh, wow, that's fascinating. Forgive my ignorance. So is it correct to assume, did you go through basic training at some point?
Yeah, so it's interesting for USIS or USU. You actually end up doing the officer basic training. So it's a shortened version of regular basic training. It's typically for officers. I think mine was 6 weeks. So it's a lighter version of what other folks go through. But it was definitely a great experience. They teach you all the things, right? So how to salute, how to wear the uniform. So definitely needed and a great experience.
Okay. Oh, wow. And then if, right now, if I said drop and give me 20, is that something you could do?
I think so. Yeah. They still keep us in line even as colonels. So.
Oh, that's great. Well, can you tell us, are there differences in how the clinical care is delivered at your military institution compared with, say, an academic center or a community-based allergy practice?
Yeah, definitely. So, I mean, I do think we have a lot of commonalities, right? So, military medical treatment facilities are treating a broad range of ages, right? So, from young infants, birth and up, right, to obviously our active duty military members as well as retirees. So, it does encompass kind of a broad range of ages as well as conditions. We also share some other headaches with kind of academic and community institutions, such as prior authorizations, right? So the administrative requirements, unfortunately, don't go away, even at the military treatment facility. But I do think the main distinction is that focus and readiness. So specifically when it comes to our active duty members, right? So it's my
Mm,
job as that military doctor to make sure that I've maximized medical care so that when they get orders or a mission to go do whatever task they have to do, that they're medically ready, they're medically fit to be able to do those things. So we definitely focus heavily on preventive medicine, which I think is really one of the main reasons why, allergy was such a good fit for me when it comes to immunizations, right? Being able to
mhm.
protect our airmen, our soldiers, our sailors with immunizations, kind of providing that preventive care so that they can go out and do the mission. Which again, it's a different focus than what you would normally see in community based or academic practices, but it's definitely something that is needed and is super important for the health of our forces.
Well, that's so interesting. Your passion for this clearly comes through right off the bat here. But if you had to list maybe like one or two of your favorite aspects of being a physician in the armed forces, anything come to mind? What would they be?
Yeah, I mean, I definitely think, the people that I've met along the way have had a huge impact, and I think that goes across all levels, right? So, currently, the fellows and the medical students that I see and teach every day how to be an allergist, right? To the staff in my clinic, and then even the patients. Like, it's awesome to be able to talk to some of our veterans, folks that served decades ago, and just to hear their experiences. Like, it's rewarding and it's fulfilling, and like I said still in, which is, I've had these awesome experiences. So very unique, and again, goes without saying, some of the camaraderie that goes along with, just being in the military is also, can't find that anywhere else. Definitely a reason why I continue to stay in.
Okay. For our audience who's listening, Dr. Adams and I, met for the first time recently. We were at a regional allergy society meeting together, and during that meeting, I heard you give one of the best lectures I've ever heard about fire ant hypersensitivity and also treatment with immunotherapy. It was great. What got you interested in both venom and vaccine allergy, which are two relatively niche areas?
That's very nice of you to say. Thank you. Yeah, so I mean, I definitely think my training at Wilford Hall, as well as experiences, during and after fellowship, impacted my interest in both of those topics. As a fellow, I was able to participate in a few fire ant studies that were going on in the department. So that definitely sparked my interest in kind of fire ant allergy and then venom allergy as a whole. I've also had some great mentors along the way who have continued to encourage me and obviously given me some opportunities and sponsored me along the way, kind of in my venom research, which is great. On top of all this, we see fire ant stings so commonly in San Antonio, but despite that, we still we know a lot about venom allergy, but there's still so many unanswered questions about fire ant allergy specifically that really wants me, I want to get answers to those questions, so that spurs my interest. From the vaccine standpoint, so definitely my interest in vaccines, I think, started out as a necessity. So, in the Air Force, allergists are the ones that run immunizations programs, and that
Mhm.
ranges from really small programs at small military treatment facilities where you might have to vaccinate 1,000 people, right? At Wilford Hall, our population is about 240,000, so it's significant. And then on top of that, we also manage the trainee vaccination. So anybody that enlists in the Air Force comes through San Antonio for basic training, and we're responsible for vaccinating those individuals, which is significant. So to the tune of over 300,000 vaccines per year. So again, we train our fellows and our Air Force allergists to be able to run these programs. So you have to get really good at vaccine delivery, at policies, at making sure that there's safety, when we talk about vaccinating such a large group of individuals. So I definitely think my interest initially was very much a necessity. I needed to get really good at vaccines. And then I think over time, it's definitely continued to grow. And then it's changed where now I want to, think more than just managing the process of vaccination, but really talking about, continuing research, some of the education, promoting vaccines, both within the military system as well as outside. So it's definitely morphed, but definitely an interest that still remains for me.
That is such a unique aspect of your position, and allergists in your group of being sort of in charge of immunizing all of the folks that come through. And that's something that, most of us in academic-based or community-based practice, we're not vaccinating, hundreds of thousands of people every year. And I think that's why you're a great guest for this. And now as we shift towards really improving our understanding of adverse reactions to vaccines and the topic of today's conversation and the new education course we're going to talk about, can you just start by defining, so just for our listeners, so we're all on the same page, define what a vaccine is for the purposes of our conversation.
Yeah, sure. So I would think of a vaccine as a preparation. So typically, like a biological preparation. So it's something that is made to provide immunity against a specific infection or infectious disease. Typically, vaccines are going to contain agents that are going to resemble the disease-causing microorganism, whether it's a bacteria or a virus. And typically, we make these vaccines by using weakened or killed forms of that microbe or the toxin that causes issues in the body, or something like a surface protein. When we administer these vaccines, really our goal is to stimulate the body's own immune system to then recognize and then combat that infection in the future without causing the disease itself. I look at them as really like we're really just prepping the immune system so that it works more effectively, so that it works faster next time you're exposed to that infection. Again, to provide that protection for you.
Okay. So we want to provoke an immune response. That's the entire purpose of providing a vaccine. And
Mhm.
as we talk about adverse reactions, what are some non-immunologic adverse reactions to vaccines that people can experience?
Yeah, yeah. So there's definitely several examples of kind of these non-immunologic reactions, and really, I define those as any reaction that is not thought to be due to the immune system response. So some of these can be very common and can occur with other kind of medical procedures, right? So, for example, a very common type of reaction that we see is called vasovagal syncope, which is really just a fancy way of saying that someone may have fainted or might have become may have felt like they were going to faint after a vaccine is given. This type of reaction can occur definitely with vaccines, but can also occur with other things like other scary medical procedures like blood draws. And if we know that a patient is predisposed to these types of reactions, we can do something about it. So, for example, we can either you can make sure the patient's hydrated. We can vaccinate them sitting down or sometimes laying down to try and prevent those symptoms from happening. Another common reaction that we've recently labeled and talked a lot about is it's called immunization stress related response, or ISRR. And what this is, it's a kind of constellation of symptoms where patients can present with different symptoms, but are typically related to kind of just the anxiety or the stress that's related with getting an immunization or a vaccine. Some of the symptoms that we see can range from like stress induced flushing to an elevated heart rate, palpitations. Sometimes people feel short of breath. They might even have vasovagal syncope where they feel faint or that they're going to pass out. Some folks, again, it's very stressful, so they might hyperventilate a little bit, which just means they're breathing a little bit faster. And that can lead to things like tingling of the face, tingling of the fingers. Some folks can have weakness in their arms and legs as well. And again, if we know that these symptoms have happened before or that someone's predisposed to them, there are things that we can do in terms of, making sure that we're vaccinating them in the correct location, as well as, providing things like hydration and whatnot to hopefully try and prevent these symptoms from occurring.
What was that acronym again that you just described?
Yeah, so it's called immunization stress related response, or ISRR.
Okay. Is that an actual ICD-10 code, or is that more just a description of these symptoms that occur with vaccination?
Yeah, so it's more of a description.
Hmm.
It got coined a few years ago, and I think again the folks that do vaccines or give a lot of vaccines. I think we've all known that these types of responses have been out there for a long time, but now that we have kind of this term to describe it, it makes it easier because then we can all talk about it and learn about it. I think in the past we used to talk a lot about kind of anxiety, kind of
Hmm.
related reactions, but unfortunately that just didn't kind of capture all the symptoms that go along with this condition or this kind of reaction. So I do think this term is a little bit more encompassing. It gives us a little bit more information. And, it's good to put labels on things, right? Because then again, we can learn more about it and then hopefully try and prevent it.
Yeah, absolutely. And it's easier to explain than telling somebody kind of like it's all in your head or it's an anxiety, attack or something like that, right?
Y- Yes, definitely. Yeah.
Yeah. Oh, okay. So how would an allergic or an immunologic adverse reaction to a vaccine present then?
Yeah. So, right. So, the allergic side or the immunologic type of reactions are typically going to be quicker in onset, usually within minutes, really no more than 4 hours after a vaccine is given. So, again, typically symptoms are pretty quick in onset. The symptoms themselves can vary both in severity as well as to what organ system is affected. So, for instance, cutaneous or skin symptoms could include something like hives, itching, you can have swelling. The medical term for that would be angioedema, and that could be in the face or the hands. You could get respiratory symptoms, which would include things like difficulty breathing, coughing, wheezing, as well as gastrointestinal symptoms like nausea, vomiting, and diarrhea. And then, really, what we look for is a constellation of all these multiple symptoms as well as organ systems would then point to perhaps a diagnosis of anaphylaxis after a vaccine. And even though I mentioned all these symptoms, I do want to note that typically life-threatening anaphylaxis due to vaccines, it does occur, but it's a really rare phenomenon. We're talking about reactions occurring in the order of 1 per million. So
Mm,
again, we want to make sure that we're aware that they can occur, but it's rare for us to see these types of reactions in general.
okay. What about, the localized swelling and redness and warmth that occurs 24, 48 hours after immunization? Is that an immune response as well, or do we need to worry about that?
Yeah, so those are called either a local reaction or a large local reaction, depending on the size. These are actually expected kind of side effects or adverse effects after vaccines. I look at them as, hey, we're stimulating the immune system, and we can definitely see these happen with different vaccines. It is an immunologic reaction because, again, we're stimulating that immune system, but having local reactions does not increase your risk of having anaphylaxis in the future with the future dose. So typically we can treat symptomatically if it's bothering you, but oftentimes the local or the large local is going to go away on its own. And again, it doesn't put you at higher risk with future doses.
No, it's a great explanation. It's interesting. Our daughter experiences this after many of her
Oh, yeah.
immunizations, and I'll never forget one time. I think she was in the bathtub when she was younger, and she said, "Oh, look at my arm." She was a little worried, and I said, "Hey, congratulations, honey, your immune system's working." And it says, "Thank you for getting the vaccine." And she went, "Yay!"
That's great. Yeah, no, definitely. Yeah, I say that in my clinic all the time. So, yeah, we want to encourage it. So,
Yeah. All right. Okay. So now you've described non-immunologic and immunologic adverse reactions, and there's some overlap there, right? It can be a little tricky. So, what types of questions should healthcare professionals, ask about to start to differentiate an allergic reaction from a non-allergic adverse reaction after vaccine administration?
yeah, no, great point. So, yeah, there can be a lot of overlap. So, I definitely think differentiating between the two different types has to start at the beginning. And what I mean by that is it's your history, right? So, I think obviously the onus is on the healthcare professional to find out what happened. So, what were there any events leading up to the vaccination? What happened during the vaccination itself or immediately afterwards? If a reaction occurred, how was that treated? And then, again, some of the historical things that you want to kind of obtain from the patient as well would be, well, what about previous vaccines? Did you have any problems with those vaccines? Is this the first time you received the vaccine or the second or the third time? And then lastly, it would be, again, getting, that complete medical history, especially for vaccines. We want to talk about, what about other reactions to things like foods or other drugs? Because again, that might help clue you in as to, this is an allergic reaction or a non-immunologic reaction. And then that will also help you with if testing needs to occur, kind of help drive your testing as well.
Okay. Let's say we've done our diligence, we have a patient, and we have a strong suspicion that they've experienced a true allergic or immunologic reaction to a vaccine. What are some of the components of vaccines that we should be thinking about that could cause these sorts of reactions?
Yeah, great question. So there's definitely several ingredients in vaccines that have been studied and potentially implicated as causes for these allergic reactions. For example, there's food derivatives such as gelatin, which is typically used as a stabilizer in some vaccines. Things like vaccines like MMR, varicella, which have been associated with allergic reactions in the past. Yeast is an example of residual media, just how the vaccine is prepared. Sometimes there's some yeast in the vaccines. Hepatitis B vaccine, the human papillomavirus vaccine may contain some of these yeast components. And again, in a susceptible individual, that might be an implication for a vaccine-related reaction. There's topical antimicrobials that we add to vaccines to prevent bacterial or fungal growth, kind of as part of the manufacturing process. And again, in some individuals, those may be the reasons why they might have an allergic reaction. Again, kind of like anaphylaxis, there's exceedingly rare reports of patients that have reacted to kind of these ingredients or these excipients. Most of these are going to be quite rare, and it's interesting that the overwhelming majority of patients that have an allergy to these substances can still tolerate vaccines, without any issue. So, and the thought there is that there may be just insufficient amounts of those ingredients in vaccines to then provoke reactions.
I didn't hear you mention latex. Is that something we should put on the
Yeah.
list as well when we're using these multi-dose vials that you have to keep putting, needles in and out of?
Yeah, great point. So the thought is that latex is found in the stopper vial or sometimes the syringe caps or the tips of vaccines. Definitely, I would recommend looking up, the excipient or the ingredients table. The Centers for Disease Control has some great charts on the web that tells you which vaccines might include these.
Mm.
I do think that for some individuals, latex might be a problem. There are some studies maybe pointing towards the fact that there may not be as much latex as we originally thought. And kind of what you alluded to is as we're giving vaccines, we're puncturing that stopper and potentially, diluting the vaccine with some latex protein. But it's unclear how much latex is actually in these vaccines. So again, you take precautions, you ask the questions.
Mhm.
Folks that have had latex allergic reactions, you want to have a shared medical decision discussion with them. But in general, like folks that have just contact dermatitis with latex, it's okay for them to receive those vaccines.
Okay. What if somebody comes in for evaluation because they had a suspected vaccine reaction? Are there any circumstances where we can just, clear them right on the spot of not having an allergic reaction to it based upon the history alone, and just have them receive the vaccine again without any precautions?
Yeah, definitely. So I think it goes back to the history, right? So, like, let's take, for example, a patient who has hives or urticaria that starts the day after a vaccine is given. Again, without any immediate symptoms immediately following the vaccine, it's really unlikely that that rash is because of the vaccine
Mm.
administration. So, potentially you could clear that patient to receive future doses without any testing or any precautions. I think another example is what we already discussed with local reactions. Again, the thought is that it's not going to put you at higher risk or at any risk with future doses. So, history of local reactions, you're clear to receive future doses without any testing or precautions.
Okay. You raise an important point, and one that I haven't thought of in a couple of years since the COVID-19 pandemic was in its, the high point. But when we give immunizations or vaccines, uh, symptoms that occur at any point afterwards, a lot of times people will go back to the vaccine as being the causative agent. And if you could just clarify, when it comes to at least allergic adverse reactions, we really need to see a timing of onset pretty soon after vaccine administration, right? So if symptoms occur 2 weeks later, 3 weeks later, it's very unlikely that it's a true immune response to the vaccine. Would that be safe to say?
Yeah, I think for anaphylaxis in particular, kind of that multi-system disorder, it's going to happen within minutes to at max, I would say about 4 hours or so. So, really, a lot of times, symptoms that occur after the fact, so beyond those 4 hours, it's unlikely to be anaphylaxis or put that patient at significant risk. Now, I will say you bring up great points about the COVID vaccine and the COVID epidemic, right? There's definitely certain vaccines that might increase your risk of having delayed local reactions where symptoms are occurring weeks later. And again, the thought there is it's still immunologic. We're still very unclear as to the exact cause of why it's delayed reactions in these individuals. But oftentimes, even having that delayed local reaction is not going to prevent you from receiving future doses. Again, we want to take the history so that we can then prepare our patients and make sure that they have expectations of what's going to occur or what can occur, but that won't necessarily prevent you from providing that vaccine in the future if it's needed.
Okay. Well, let's go back to the more scary scenario. Let's say we have somebody that has a history that is concerning for that immediate onset IgE mediated reaction or anaphylaxis. What type of testing can and should be performed in those patients?
Yeah. So we definitely have testing protocols that are available to evaluate those patients. Again, the ones that we're worried that might have kind of anaphylaxis or that risk for anaphylaxis with future doses. And I really like to think of this testing as being a guide for us to be able to then provide kind of personalized vaccine recommendations. Our testing can include skin testing, which you can do prick testing as well as intradermal testing. It's typically a pretty well tolerated procedure. And then if an individual, again, has a concern about a vaccine, we want to test to the vaccine itself, as well as any excipients or ingredients like the food, like gelatin that I mentioned, as we're doing part of our evaluation. Depending on the reaction as well as availability of testing, we can also consider doing serologic testing. So that's a lab test where we look for that long-lived immunity to a vaccine or a disease. And what we're doing there is we're checking immunoglobulin G, which is kind of the antibody that is thought to provide protection. Again, that long-lived immunity for patients that have already built immunity against an agent or vaccine in question, and that's going to help determine whether or not future doses are needed to the vaccine.
Okay. When should we consider graded dose administration or challenges or in office administration for subsequent doses of vaccines?
Yeah. So graded challenges are typically offered to patients where we've done skin testing to the vaccine or those ingredients, and the test is positive or it's abnormal. So now, we're concerned that we found evidence of IgE. And again, if that patient needs a vaccine in the future, we might be putting them at risk if we just gave the vaccine. So a graded challenge is it's a stepwise process where we give the vaccine in small increasing concentrations or doses to achieve a full dose of a vaccine and then tolerance as well. I will note that having a positive test alone is not necessarily predictive of having a subsequent reaction, but we do see it as kind of a significant risk factor, right? So again, a positive skin test might tell us, hey, we can probably still give the vaccine, but let's do it slower to make sure you
Hmm.
tolerate it. I will also say that, again, because there's this risk of potentially triggering an allergic reaction, we do want to make sure that challenges are being done by providers that are trained to do those challenges, as well as trained to recognize allergic reactions, as well as treating anaphylaxis. For patients that have a negative skin test, the chance that IgE antibody to a vaccine or component is present is actually pretty negligible. So in those individuals, we can actually just consider giving them the full dose of the vaccine without the need for that stepwise approach or that graded challenge. Um, if there's a patient who has a very convincing history of anaphylaxis, severe symptoms, if their skin testing is negative, I would caveat that it might still be prudent to do the vaccine under observation. But
Hmm.
again, I think this is where kind of that shared medical decision piece comes in. You want to talk to your patient to find out, what they're comfortable with.
Okay. Do you remember the days when we used to torture those poor children with egg allergy when we gave them their influenza vaccines with like the
Yeesh.
five-step dose graded protocols? Oh my gosh.
I sure do. Yeah.
Oh, I'm glad we moved past that. Oh.
Yeah.
Um, wh- if somebody has a legitimate IgE mediated hypersensitivity to a vaccine or vaccine component, do they need to strictly avoid that vaccine for the rest of their life, or can they gain tolerance over time?
Yeah. So I do think individuals that have kind of that legitimate IgE mediated hypersensitivity where you've tested and found evidence of it, potentially they would need to avoid that offending vaccine because again, they might be at risk of reactions in the future. But like I mentioned, there's strategies and circumstances where they might still be able to receive the vaccine safely. So again, an example would be through a graded challenge, right? I
Hmm.
think the other key to consider is like the development of new vaccines has exploded in recent years, right? So there's lots of new vaccines coming on the market, and I can imagine a situation where a patient who had a reaction to a vaccine or an ingredient in a vaccine may in the future be able to receive a similar vaccine that's done by a different manufacturer that doesn't have that ingredient or that excipient. So I do think it's important to remain vigilant. As the allergist, make sure we're aware of kind of the new vaccine products that are coming on the market and indications because we might be able to help these patients down the line.
Such an important point that you mentioned. I had not thought of previously. So, walk us through the steps. Let's say we have somebody that had a suspected IgE reaction to a vaccine, I don't know, 10 years ago, and they need to have another dose of that vaccine for whatever reason. Walk us through what does that look like to try to figure out can we give that to them again if there's an alternate, formulation
Yeah.
available?
Yeah, so I mean, again, it goes back to the history, right? So you want to figure out what vaccine they received, what reaction they had. Look for your resources. So, like I mentioned, the Centers for Disease Control has some awesome charts that look at excipients and ingredients, and it directly tells you what product and what excipients or ingredients are in those vaccines. Again, you want to get a great history about food allergy, other drug reactions. And then as you're looking at potentially new products out there, what you're looking for is there a new vaccine that doesn't have whatever ingredients you were worried about to begin with, right? And if that's the case, then again, you talk to the patient. Shared medical decision making is important, right? To potentially offer this new vaccine product to get them kind of the protection that they need without exposing them to that risk of that previous vaccine.
Okay. All right. Really silly question, but just to set the record straight, can somebody be allergic to the antigen itself, whether it's a piece of the bacteria or virus?
The thought is that yes, there's potential there. There's some case reports and case series that might point to that, but it's pretty rare. So oftentimes we really are looking for those excipients or those ingredients in vaccines as potentially the target. I mean, one of the ways to test for this is you again skin test to the vaccine itself. So that's a way to kind of screen for that concern. But I would say in general, it's pretty rare.
Hmm. Okay. Why is it important for board certified allergists and immunologists to evaluate anybody that's been labeled as having a vaccine allergy?
Yeah. So I definitely think it's essential for allergists to evaluate anybody with a vaccine allergy. I think we've got this specialized training that we all go through that teaches us how to distinguish between IgE reactions versus not or other adverse responses. I think this also means we have the kind of detailed knowledge of the vaccine components, ingredients, the immunologic kind of know-how as well to explain why these reactions occur or what risk factors a patient might have that I think then get us to hopefully get to an accurate diagnosis as well as risk assessment. I think we're well equipped to implement these personalized immunization recommendations, include things like graded challenges if needed, and then also provide education on alternative vaccines like we just talked about or kind of risk management strategies. I think big picture, it's I think our expertise that kind of helps prevent misdiagnosis for
Hmm.
vaccine allergy as well as unnecessary vaccine avoidance. And then, obviously we're contributing to public health efforts by being able to do all of this.
I think that's a great plug. Can you think of any outdated myths or misunderstanding regarding adverse reactions to vaccines? Anything come to mind?
Oh my gosh, there's so many. I don't think we have all day. How about I give you my top three?
Oh,
Um,
okay. Yeah.
there's a ton of these.
I know,
So
right?
I
Oh
think
my gosh.
like the common ones, I would say, like one that I hear all the time is, oh, vaccines, they overload the immune system. Like, why are we giving so many
Mm,
vaccines, right? And I think, again, vaccines are studied carefully before they're brought on the market. They're designed to stimulate the immune system without obviously causing that disease. The antigens in a vaccine are just a tiny fraction of what a child or an adult sees, what their immune system sees on a daily basis. So really, we can handle multiple vaccines at once. Our immune systems are pretty sophisticated, so um, not a concern in terms of receiving multiple doses at the same time. So myth two would be that natural immunity is better than vaccine immunity, and again, while natural immunity obviously is going to provide some protection down the line. It also does carry some risks, right? So severe illness with the natural disease, complications, and then transmission to others, right? If you're actively sick, you're putting others at risk. With vaccines, we're providing that immunity without putting others at risk or putting you at risk with those natural infections. And then I would say my third kind of myth is that vaccines are not necessary because of the diseases that they prevent are pretty rare, which I think is a plug for just the public health aspect of vaccines and the fact that we've been able to drive down some of these you know common childhood diseases to really rare kind of events. But the downside is as soon as folks start to not vaccinate and unfortunately as those vaccination rates go down, that means that these infectious diseases can come back out, right? And we have outbreaks that are reported. I think recently there's measles outbreaks in the news as well as pertussis outbreaks. So unfortunately we haven't fully eradicated the world with all these pathogens, so we need to keep up with vaccination to prevent kind of those issues.
Yeah, well, I think those are three very good ones. And then let's go back to what we touched upon before with egg allergy. Is egg allergy a contraindication to any influenza vaccine?
Yeah, so great question. Yeah, so the data points to the answer being no. So in the
Mm.
past, we used to be very worried about the amount of egg protein that was in vaccines, and I think studies have shown that amount is very, very small. There's been lots and lots of studies done on egg allergic individuals that are then safely able to tolerate flu vaccines. So yeah, it's not a contraindication. You're welcome to receive any flu vaccine without any precautions. So I think that's a great news story for us. Like you mentioned, we used to test a lot in the past, and um, we don't have to test anymore. We can just give the flu vaccine.
Hmm. Well, something everybody listening to this lived through recently was, when the COVID-19 pandemic, when they first rolled out public vaccination campaigns in the winter of 2020-21. This really provided real-time headlines of every suspected allergic reaction to these new mRNA vaccines and the subsequent hysteria that came from this. I'll never forget. It was like the first week, I think, in Europe. They had two patients with suspected anaphylaxis. And initially, there were suspicions about polyethylene glycol being the culprit, and then other theories that led to these extensive testing regimens or avoidance of subsequent doses. What have we learned since then? It's been a few years. Is there a final verdict in this case? Is there a best course of action for anybody who experienced or experiences a suspected allergic reaction to any COVID vaccine?
Yeah, great question. So, yeah, we've definitely learned a lot about COVID vaccines since the initial vaccine rollout. And it's interesting that there were actually no anaphylactic reactions that were reported in the clinical trials that led to the approval of
Mm-hmm.
the vaccines. But yeah, like you mentioned, I mean, I want to say it was within the first couple of days of those doses being given that we already had reports of folks having reactions. In particular, this is going to be to the messenger RNA or mRNA vaccines against COVID. And as you mentioned, there's a lot of theories early on about the cause for these reactions, where polyethylene glycol or PEG kind of started to stand out as a potential culprit. But over the course of the last few years, there's been a ton of data collected, a lot of research done on this at multiple institutions with multiple, populations, which have actually confirmed that PEG is unlikely to be the cause for those reactions to the mRNA vaccine. Um, PEG allergies can occur, but typically these are very uncommon. So again, it's unlikely that these are the sole reason for those allergic reactions. And again, retrospectively, we've gone back and looked, and it's interesting that some of the initial cases that were characterized or diagnosed as anaphylaxis after COVID vaccines have actually been subsequently determined to not have been anaphylaxis. So if you remember that immunization stress-related
Mm-hmm.
response or the reaction that I mentioned before, a lot of these folks have actually been reclassified as perhaps having that ISRR type of reaction because of the symptoms that they had, which included things like itching or tingling, subjective throat swelling, without any objective signs or symptoms of anaphylaxis. So again, the thought is that perhaps it was more of an ISRR or stress-related response rather than anaphylaxis that caused those reactions. Um, so again, it's definitely again another good feel good story in terms of kind of the amount of research that's gone into this to kind of help differentiate and make us feel good about perhaps getting additional doses. There's been studies where folks have gotten revaccinated with COVID vaccine after having mild reactions in the past, and they've been able to tolerate subsequent doses without any testing, without any pre-medication. So, again, a plug for research and studying these types of reactions.
Yeah, go science, right?
Yeah.
You probably have either administered and or evaluated more folks with suspected adverse reactions to vaccines than most of our colleagues. Do you have any interesting anecdotes or stories about vaccine reactions?
Yeah. So one story comes to mind, which I really think kind of highlights the role of allergists, right? In immunizations, whether it's evaluating adverse reactions or just giving vaccines. So it's of a patient that received pneumococcal vaccine. They presented with significant pain and swelling of the upper arm, so the site where the injection was given, within hours of receiving the vaccine. Unfortunately, the patient didn't come back to the allergy immunizations clinic. They went to the emergency room where, they were very concerned. They got lab work that showed an elevated white count. They actually got a CT of the upper arm that showed significant muscle edema, and they were really concerned about infection. So they consulted a surgery team who actually was very concerned about necrotizing fasciitis.
Wow.
The patient ended up getting IV antibiotics, actually went back to the OR for a fasciotomy where they really, when they went in and looked, there was healthy tissue. They did biopsies that really weren't revealing. So at the end of the day, it was a very robust large local reaction that the patient experienced. And I kind of share this as a cautionary tale, but I do think it highlights the role and expertise that we as allergists can provide, and not just educating our colleagues and our patients, but again, that expectation management about vaccine reactions is so important. And again, that's where I think our role is highlighted.
That's a very dramatic example of people trying to connect dots that don't connect.
A
That's really
hundred
interesting.
percent. Yeah.
Wow. Well, you gave a great explanation and just highlighted by this anecdote about why allergists and immunologists should be involved in the evaluation and management of anybody with a suspected adverse reaction to vaccines. So, can you offer some background as to why the American Academy of Allergy, Asthma, and Immunology developed this new CME course focused on adverse reactions to vaccines?
Yeah. So we have a new CME course, specifically looking at adverse vaccine reactions. This was actually developed initially through the vaccine committee for the Quad AI. So a plug for committee work. It was a group of individuals that we felt like we wanted a creative way to deliver educational content that was easy to digest and interactive, which is kind of how the course came about. And like I said, a lot of this is like, it's passionate individuals that feel really strongly about vaccines and education on vaccines, which is kind of, how the proposal went in and got accepted and whatnot. So, yeah, that's how the course came about.
Okay, so another example for our listeners of something originating on the level of the committee and then turns out to be part of the educational content. Where can members access the curriculum?
Yeah, so it's available through the Quad AI Continuing Education Center. So on the web, you can access, sign up for it and then do it online.
Okay. What can we expect as we take this course? Is it just sort of like didactic lectures and sort of PowerPoint slides? Or are there cases? Tell us what type of learning we can expect to encounter.
Yeah, so like I mentioned, we really wanted this to be interactive. So we opted for a self-paced course. It's made up of several different modules, things like categorization of adverse vaccine reactions, what's the diagnostic evaluation. There's definitely some interactive exercises throughout the course. And then at the end, we present you with some case scenarios with some questions to kind of test your knowledge. And then finally, we really wanted this to be practical as well. So through the course, there's tables and figures that can be downloaded. So you can use those as you go through the course and definitely afterwards, right? So copy them, print them out, put them next to your desk so that you can use them as you're evaluating patients.
What does this cost for Academy members to take the course, and is it available for non-members?
Yeah, so it's free for Quad AI members. And then for non members, it's also available. I believe there's a $25 registration fee.
Okay, yeah, that's on par with a lot of the other educational offerings we have. Dr. Adams, you have a personal interest in vaccine allergy, tremendous experience in this realm. What's your call to arms to get all of our colleagues to become more interested in learning more and to take this new educational course?
Yeah, definitely. So, I mean, I definitely think that vaccine allergy is not just about providing good patient care or knowing about vaccine allergy. Obviously, it's going to help our patients, but I do think it's safeguarding kind of that public health and preventive medicine kind of aspects of our job. I also think it's important to help combat vaccine hesitancy. Again, I think as allergists, we've got expertise in this area that's going to help us provide accurate diagnoses, manage patients, manage their fears and concerns. Like we talked about already, there's so many myths about vaccines out there. And I think as allergists, we can help dispel those myths and provide kind of that patient centered treatment as well as education recommendations. And again, as we do this, we are empowering ourselves to be able to advocate for evidence based practices. Again, a plug for research and science,
Mhm.
and then kind of improving those public health standards, which is so important.
Mm. This has been an extremely helpful conversation. You've given us a wealth of knowledge. I encourage all of our listeners to take the online course to learn even more. Did we miss anything?
No, I think we covered it all. We covered a lot.
Yeah, no, I agree. This is great. Dr. Adams, thank you so much for taking time out of your schedule to join us today. Is there anything else you'd like to add before we depart?
Oh, just thank you again for inviting me. It was super fun.
That was our pleasure. Thank you. We hope you enjoyed listening to today's episode. Please visit www.aaai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Amazon, iHeartRadio, or Spotify so you can receive new episodes in the future. Thank you again for listening.